And Dr. Helen Dickinson is a senior lecturer in healthcare policy and management at the Health Services Management Centre, University of Birmingham, and also director of the Public Service Academy. She's published extensively on the topic of integrated care, including the Better Partnership series published by the Policy Press. And her title this afternoon is What Works? Joint Working in Practice.
Hello, good afternoon. Welcome, well done for making it through to this final session of the afternoon. So I've spent a long time kind of researching and thinking about and advising local and national organisations about joint working over the last 10 years or so. So I was asked to come here this afternoon and think about what works in terms of joint working in practice. So I don't have a set of case studies here that I'm going to present to you. I think you've heard quite a few of them already today. This is some of them more about the kind of principles and the factors that will help you to be able to deliver joint working in practice. And I guess that's important because there is this sense that joint working is a really important thing to do. So we know all the stats about kind of changing demographies in terms of the country and the sickness profile of our population. We know all the facts about the fact that we can't deliver any of these difficult issues around social exclusion, around poverty, around health inequalities, unless we work together jointly. So there is a general perception that joint working is a good thing, and if we just do more of it and we do it a bit better, then we'll be able to get to the end point. And I guess starting with the bad news, but I guess the news that we have from our research is not quite that easy, actually. And joint working takes a hell of a lot of effort and thinking about if it is going to be able to deliver all of the things that we want it to deliver. So in terms of the policy context at the moment, we see any number of things like this. This came out a couple of weeks ago from the Department of Health, the idea that we'll all have joined up services by 2018, which is a fantastic aspiration, and I would love to live in the place that manages to do that joining up of services. But if we're going to move from where we are now to then, there is a lot of thinking through and a lot of things that need to be put in place. So thinking about why we might do joint working, I mean, these are fairly well rehearsed. I'm sure you've heard about them today and in previous weeks and months. But this idea that an increasingly disaggregated system where we have a greater number and variety of types of organisations involved in delivering health and social care services, some of which will be statutory, some of them will be non-statutory, then actually we need to think about how we join them up. And that's particularly important where you've got frail, elderly populations, people with complex needs. We need to think about how we do that. And that's not just a problem that we have in the UK. You go to any number of countries across the world and they're similarly grappling with these sorts of issues. The what is a bit of a difficult one, though, in thinking about what joint working is. If you look in the literature, as I spend a lot of time doing, there's a whole different set of terminology about what joint working is. Some of these terms are different, some of them aren't, sometimes they're defined, sometimes they're not. And I guess the important thing here is that there isn't just one model or one way of going about joint working. And so this might be a terribly academic thing to say, but if you can define what you mean by joint working when you set about going about doing this, then you might help your partners to have a better understanding of what you're trying to do in terms of joint working. The why of joint working is also important as well. So thinking about the types of outcomes that you're trying to deliver. This list here are taken from an Audit Commission report from quite a few years ago, and it captures some of the different things that joint working can do. But there are a whole set of other things that we see that people say joint working might do. In some research that I've done before, we've gone into an exec team who've just set up a partnership and said, well, what's your partnership going to deliver? And the 5 people in the room thought it was going to deliver everything from faster, more effective clinical care through saving money to introducing more car park in the facility and introducing more Turkish interpreters. And it might have done some of those, But the issue there was everybody had a different idea of what they were trying to do in terms of that joint working. Not necessarily a problem at the start, but you can imagine down the road that they can become issues when it starts to not deliver what you think it's trying to deliver. So it can be about coordination, it can be about dealing with those wicked issues, about sorting out fragmentation, but it can also be because it's a statutory requirement, because you're told to do it, or because there are some resources that you might be able to get hold of that will help you to do this. Obviously, under the previous Labour government, that was probably more of an issue than maybe necessarily it was now. And I guess one of the challenges of joint working in health and social care often being associated with those additional pockets of money is that it became driven a bit sometimes by kind of funny money and would exist in the periphery of organisations and wouldn't necessarily be fully integrated into the whole operation of the organisation. But there's a range of reasons why we might do joint working. And if you go onto the internet, if you look in text, or you look in magazines, look in the HSJ or whatever, you see all sorts of stories like this of what joint working can do. So I've selected these pretty much at random, but here we see integrated care delivering cost savings. You see it supporting people with complex conditions to live at home, live an independent life much longer. And as the paper goes on, it talks about also being able to support carers as well. I'm sure you've all come across the Torbay story, you heard about it earlier today, and integration was a crucial component of that in terms of turning around the health and social care services in that locality. But then you also get less positive stories, and sometimes these are often very public stories that we come across as well. And I wouldn't want to single this out as the only example, because there are many different examples that you can use. And often the experience of that partnership breakdown is very profound, not just for the people who use those services, but also for the professionals who are involved in the delivery of those. So there's something here about, if we get it right, we can do some really exciting and really good stuff. But if it doesn't work, there's some potential jeopardy there in terms of our service user population and the staff who work within it. And if you look in the academic literature, that also agrees that joint working isn't always necessarily a positive thing. So although central government and a lot of our organisations would push the idea that integration is a positive thing, we also see these negative definitions as well. I would imagine the first one's probably quite similar to a lot of you. You put your mutual loathing aside to get your hands on the money. Somebody else has got some resources, so we'll work with them despite the fact that we don't have a very good relationship. It's not a bad reason for getting into a partnership, but they tend to cause difficulties when people aren't honest about them, I suppose. The second one is about the undefinable in pursuit of the unachievable. And as I've mentioned already, we often don't describe what we mean by joint working, and we're often not very explicit about what we think the outcomes are that are going to be delivered, which is where that definition comes from. And Thompson and Perry are some American academics who are very mean about cottage cheese, but they say, it can sometimes smell bad and it separates easily. And I guess the important point there is it can take a lot to generate trust and to get close joint working, but it can be destroyed fairly quickly and it can go bad quite quickly and quite easily. In terms of the research evidence around this, there have been a number of systematic reviews around this in recent years, and the sort of academic evidence base about whether joint working is a good thing is a bit sort of unequivocal. It suggests that there's not a huge amount of evidence to support this idea that joint working leads to outcomes, but says actually there's a lot of difficulties in evaluating joint working, not least that we don't always say what we're trying to achieve when we're trying to work jointly. And I guess the important thing, again, to stress is there isn't a single solution here around coordination or joint working or collaboration. It will really depend on what you're doing in terms of your context and also the initiative that you're trying to drive locally. But in terms of what the research evidence does say about what joint working can deliver, these are a couple of meta-analyses. So there's big studies. They get all the studies that are done around joint working and look to try and find evidence about the outcomes. And so the first one is from an Australian team who got together to look at this. And they said that actually there's a lot of evidence that you can improve organisational processes, but there's less evidence there about changing patient experience or reducing costs. Rebecca Rosen, who's a GP and a researcher at the King's Fund, in the study that she did, said, again, there's a lot of evidence that integration can improve processes and actually user experience through the system. But particularly in the short term, it's less likely to reduce costs. And John Overtveit did some work around clinical coordination, so different to organisational coordination typically, and said that actually it can save money, but you need to pay attention to how you use it. So what all this says is that if you set up kind of joint working initiative, you don't automatically get the outcomes flow out of it that you would like to have. So I think in recent years we've heard a lot about saying, well, if we just put these structures together, if we just create a care trust or we create an integrated team, then we'll be able to drive these outcomes. What this evidence base says is you can do it, but it's actually quite difficult to achieve. You need to take time and effort and planning to make sure that you get it right. So I've got a few slides that look at, well, what factors help that happen then? And so this first one is taken from an international review around care for older people, integrated care for older people. Some English examples in this review and also some from other countries as well. And they found that around older people, the things that really seem to make a difference in delivering good quality integrated care were where services had good case management. They had multidisciplinary teams who came together and thought about how they managed their cases. They had an integrated assessment, typically. In these cases, they usually had a geriatrician who was involved in those assessment processes, and that when they came together and worked well, that could be really key for older people using those services. In older people's services, single entry point also seemed to be a really important factor. So this idea of not going and not having to go to lots of different places to get access to services. Although when you look at different areas of the literature, so if you look at evidence around joined up services for homeless people or for people with chronic mental health issues, sometimes the lessons aren't as clear cut around this. So particularly if you have people who might not always behave very well, or if you take them away from one point of entry, you effectively bar them from services. So that can be really bad for some service user groups. But around older people's care, that seems to be quite effective. And I guess this last one's a really important one, and probably one that the system in some ways is increasingly working against us with. This idea that if you're using financial levers, so if you're looking for what the literature calls downward substitution, so you are using more community or primary-based care in place of secondary or long-term institutional care, then you have to make sure that the people doing the work to make that shift get the money. If you don't do that, people are not incentivized to make that happen. Obviously, that's quite difficult in some ways within the current context that we've got, but people are working through that. And so it's saying these are the sorts of things that you need to pay attention to when you're setting up integrated or joined up or collaborative services. Another paper from Natasha Curry and Chris Hammer a few years ago looked at what they call the ingredients for successful integrated care systems, and they're talking about systems in their broadest senses here, but they say it's really important that you define your population, you know who your services are for, that you're trying to integrate your services for a particular population. There's an American professor called Walter Lutz who writes about integration, and he has what he calls his 7 laws of integration. And his first one, and I'll get this wrong now I'm stood up here, but it's something like you can integrate all of the services for some of the people, some of the services for all of the people, but not all of the services for all of the people. So you need to think about where your boundaries are. You need to think about who you're trying to target in terms of this initiative, and who you're going to set this system up around. The second one is again around financial incentives. I've spoken at length around that one already. the issue of shared accountability and performance management, and using data to back that up. So that says to me, you need to be clear from the outset what you're trying to deliver in terms of outcomes, and make sure you've set up your data systems to be able to accommodate that. I think we've moved some way in recent years to maybe slightly more aligning performance management systems. There's still challenges there, but they're not as challenging as maybe they were at one time. But we need to think that through in advance, and if you don't think that through at the start, it could be something that will be difficult later on down the line. I know there's been a presentation on IT already today, information technology. Often it's one of those factors that we see come up time and time again. How you share information, how you use IT is absolutely crucial in working together. And again, one of those things that needs to be thought about in advance. So Curry and Ham also say that it's really important that you have guidelines about best practice. And I guess that's a decision that you have at a local level. But really what they're trying to get here is, if you've got a care pathway that's set up, then you look to reduce variation across and within that. And if you do that using guidelines or other means that you might be able to set up. Leadership, again, is one that you see time and time again, and the number of times I've read an evaluation and it's of a joint working initiative, and it said it hasn't worked as well as it might have done, and the factor is usually given in terms of leadership. But I guess that leadership is at all levels, so it's not just who's the exec, who's driving that. Who are your clinical leaders who are on board in there, who are your nurse leaders, who are your service user champions, what are the different mechanisms that you're using to drive leadership through the whole levels, different levels of the organisation. Culture seems an incredibly crucial one. If you don't have a collaborative culture, then you're not necessarily going to deliver very collaborative services. And that's often seen as one of those soft and kind of wishy-washy factors. Structures, payment systems, IT are all kind of quite hard, tangible things that we can go and sort out. And I guess what this literature says is, don't forget about those softer aspects. Don't forget about how it impacts on professionals who are working in integrated services. We need to think through those and make sure people are happy in terms of that. Multi-specialty groups, I guess we touched on that already in the previous slide. And a really crucial one for me is patient engagement. So are you sure you're delivering what people want you to be delivering? And how do you know that? Where's the voice of the patient within that? Bit of a long list, isn't it, in terms of what you need to deliver that. But I say those will be more or less important depending on your local context and the local circumstances. So the sorts of themes that we'd suggest, if you're thinking about joint working or you're doing joint working at the moment and you're thinking about how to deliver this, these are kind of, I think I've got 7 or 8 themes that are probably the most crucial ones to start thinking through. So I get bored of myself saying this because I say it over and over again, but think about what it is you're trying to deliver. Yes, joint working can make things quicker, safer, cheaper, all those sorts of things, but what are your top ones that you're aiming at? If your integrated services were successful, what would they look like? It's a really important conversation to have early on, and yet you'd be surprised the number of times that doesn't necessarily happen, partly because we all think joint working is a good thing, so we buy into it and we don't question it as much as you may do other initiatives. So be clear about what you're trying to coordinate, think about what outcomes you're trying to deliver in terms of this. Your structures will get you so far, but they're not going to crack it. If structures did crack it, maybe we'd have done this before now, but actually it's much more difficult than putting structures in place. We need to think of the softer elements around that as well. Don't think it's going to deliver efficiency straight away. It may do in the longer term, but a lot of the evidence suggests that you maybe need to invest early on if you're going to save later. And make sure you're clear about where those financial levers are. If they're not lined up, you will struggle to incentivise people to operate in that way. And build on strengths and successes. If you've got champions, if you've got people driving this, if you've got examples of good practice, go with it, use it. Often people say, oh, well, we didn't focus on that because they do quite well already. But often those sorts of successes are terribly good in enthusing and infecting kind of the rest of a system with a sense of good integrated working. think through how it's going to impact on your staff and spend time having conversations with professionals about this, what they'd like to see from it, what are the challenges that they face at the moment, how can you support this in making it easier. It always amazes me the number of times things kind of fail to happen, often over very often quite small reasons, but people have just not been spoken to about these changes before, and so it's become a challenge. Invest in boundary spanners. It's a terrible term. There's an even worse one in the academic literature. They're called reticulists. But people who can speak more than one language, whether that's across different professional groups, whether that's across health and social care, whatever that is, those people who can traverse boundaries are invaluable to your organisations. Invest in them. It's not an easy role to do. Being schizophrenic for having a very kind of schizophrenic life for quite a while, but if you can invest in them, they can really drive and make a success of joint working. And these last two are from Walter Lutz, who I talked about, the professor who has laws of integration before. He argues that whoever integrates calls the tune, so whoever decides you're going to integrate is going to take the lead on that, and is going to be the boss, essentially. Don't know whether I always agree with that, but what I think he's pointing to here is we often have an idealised notion that partnership or joint working, if it's a true one, means true equality between partners and everybody sharing things equal. And that's not necessarily always the case. So be aware of that. And the last one is about, he argues you can't integrate a square peg into a round hole. So if you have fundamentally different services, that have different assessment criteria, different means of financing and things, he argues integration isn't the best way to go forward. There he's talking about integration in terms of organisational integration, so like a structural integration. But be aware that where you have a number of differences, there are other ways for you to collaborate that don't involve setting up joint management teams and those sorts of things. So in terms of what I think you could take from all this, it's a developing field still. There's been a lot of academic research around integration, around health and social care in the last 15, 20 years, but we still don't have a really expansive evidence base, and it's growing all the time. And there are a number of uncertainties out there still. As I said before, structures, formalised processes will take you so far, but it's not the end of the story. We need to pay attention to these softer factors as well. Around those softer factors, particular ones you might want to pay attention to around, again, your purpose as a joint working, what you think it's going to achieve, and how you think individuals and teams within those services will contribute to those outcomes. So how does what people do on a daily basis link into your team and organisational aims? And I guess the final one is integration, joint working. It takes time, it takes a lot of planning, and it takes a lot of leadership. There aren't any quick fixes around this, so don't be afraid to take time to think about how you develop this. This is my last slide, and this is a quote that I've taken from Peter Beresford, who's a professor at Brunel University. And he talks a lot about the relationship between services and service users. But he argues that partnership working or joint working more generally isn't rocket science. He's got a quite unfair view on rocket science, according to some of my best friends who are physicists, because he says if you're sending a rocket up into space, you fill a big tanker full of lots of petrol and you light a match and it goes up, and it's quite easy to do. He says actually joint working is a lot more complex and a lot more important than that, so it takes a lot more time to develop. Thank you.